Who can fix healthcare? Some people think that doctors can fix healthcare. Trust me, I'm a doctor. We can't. Some people think that their elected representatives or other policymakers can fix healthcare. I don't think so. Not even presidents. If presidents could fix healthcare, Harry Truman would have done so just after World War II. That's when the British, still reeling from the psychic trauma of the near death of their nation, with occupied territory 20 miles away and bombs dropping on their capital, reached out for a sense of personal security in the form of healthcare security and formed the NHS in 1948, July 5th. Truman tried in this country, but he didn't come close. Every president since has tried, I must say some more than others. And we've just had a small victory, I think, in a battle to achieve some personal health security, but the end of that story is yet to be written. No, I don't think doctors or policymakers can fix healthcare. They certainly can't do it working alone, and I don't think they can do it working together. They need you. Now, some of you may be looking to your right, looking to your left, maybe me, but I don't know about him or her. And some of you may be wondering, I'm not even sure what the problem is. How can I fix healthcare? So, who can fix healthcare? Me, her, him? I think you need to understand your role in healthcare. And my guess is you don't realize it. Yes, you need to understand the problem, but you also need to understand that it's the decisions that you make about your health and about your healthcare that really drive the system. We don't have time to get down in the weeds here, so I'm just going to spend a few minutes talking about the problem. We are the richest country in the world, and we spend richly on healthcare. $2.5 trillion, 17% of our GDP, roughly 50% more than any other country. Some of you may have read the newspaper this week about 20% increases in health insurance rates for small employers in Massachusetts. Those of you who work for the college know that our employee costs for healthcare are $13,000 per year. Increasingly, healthcare costs siphon money from payroll checks and from profits, putting not only the health of people at risk when they can't afford it, but the health of our nation at risk. And what do we get for this massive expenditure in healthcare? Well, if you look at the kinds of metrics that are used by the WHO and others, we don't get nearly as much as we think we do. We're so fascinated with the high science and the high technology that we don't pay sufficient attention to the basics. By basics, I mean life expectancy for men and women, infant mortality rates, vaccination rates. For most of the past decade, our country has ranked in the mid-30s, despite the fact that we spend roughly 50% more than anyone else. Let me suggest that we don't have time to get in the weeds, but there are some other important things that you don't realize, and let's begin with a pop quiz. Question: healthcare is a good thing. True, false, or it depends? How many think true? How many think false? How many think it depends? Okay. Let me try and give you a clue or two for those of you who are still wondering what the answer is. If I were able to guarantee that you would be at the absolute top of your game tomorrow at noon, physically, intellectually, and emotionally, with or without 8 hours being poked and prodded in the DHMC EW overnight, which would you choose? A good night's sleep, or being poked and prodded by strangers in the glare of the EW? A second clue. What if it was my sad task to tell you that either you or a loved one would not be with us in 30 days? Would you prefer that with or without 3 weeks of intensive care that made the poking and prodding in the emergency room look like child's play. Which would you choose? The respirator, the catheters, the infusions, or peace at the last at home with loved ones? No, healthcare is not a good thing in and of itself. It's what economists call an instrumental good. Healthcare is only good if it sustains or improves health. Now, I've cheated a little bit on 2 counts. First of all, I offered you a guarantee. I pretended I had a crystal ball. I don't. No doctor does. Life is uncertain, healthcare is uncertain. The uncertainty is interesting in healthcare. Sometimes we're uncertain because nobody knows. We just haven't done the research. There may be a new treatment for heart disease, for cancer, for breast cancer, but we just haven't done the research yet. Either because we haven't gotten to it, it hasn't been funded, people didn't find it interesting. You could call that kind of a collective professional uncertainty. On the other hand, sometimes the research has been done, it's been done well. It's just that it hasn't been interpreted for the patient at hand. The research was done in women. Does it apply to men? The research was done in young adults. Does it apply to old adults? And even when the research has been done and interpreted correctly, it may not be there just in time to help with the decision that doctor and patient make together. And even when all of that happens, life is uncertain. We can't predict what's going to happen to the next patient. There, it's all about the risk attitudes that the doctor and the patient bring to the decision. Sometimes we like to think we can control the future. Sometimes we like to pretend that we're not making decisions in the face of uncertainty. But it's critical that we make the distinction between those things that we can't control and those things that we can't. And there's no sector where that's more critical than in healthcare. I've cheated in a second way. I talked about top of your game, perfect health. That's that little figure over there on the left. On the one hand, and death on the other. There's a lot in between, isn't there? We could talk about those dimensions of physical fitness, of intellectual capacity, of emotional resilience. All of those things contribute to the gradations of health between perfect health and death. And you know what? Many people would be surprised at how much they might disagree about how good or bad a particular health state is. For instance, men of a certain age, I won't mention it, learn that their urinary function declines over the years. They may have to get up once or twice a night if they drink after 6 o'clock. They may have to stop 2 or 3 times on a long trip. They may have to sit on the aisle at an event like this. And that can usually be fixed pretty quickly with a surgical procedure, but it almost always produces a certain odd kind of sexual dysfunction. Some men are perfectly happy to trade away sexual function for some improved urinary function. Others are not. They disagree. When a woman is told that she has breast cancer, she might feel that keeping her breast is not terribly important to her. And it would be just awful to have breast cancer occur in a breast that she chose to keep. Another woman might feel just the opposite. They might disagree. It's this uncertainty and disagreement that makes healthcare so complex. And I think you can begin to see why your role in sorting out the complexity is so important. This is after Ralph Stacey, management organizational behavior professor in Hertfordshire in England. It's called the Stacey diagram. Basically, when uncertainty is low about getting B if you do A, and disagreement is low about how good or bad B is, decision-making and execution can be simple. When uncertainty is high and disagreement is high, decision-making and execution can be chaotic. Most of life, and certainly most of healthcare, is in this zone of complexity. It's the profession's job to reduce the uncertainty as much as possible, but remember, there's going to be that irreducible uncertainty left. It's not the profession's job to try and get people to agree, to try and get two men to agree about the trade-off between urinary function and sexual function, two women to agree about how bad it is to live without a breast, how bad it is to live with the prospect of a recurrence. Now, this complexity is very interesting, and it may remind some of you of the phrase fog of war. Fog of war is a phrase used when people have to make decisions in a great hurry. And those decisions are made in the face of uncertainty and ambiguity and often faulty intelligence. It's also a phrase used when things aren't going so well. I think we're dealing with a fog of healthcare. What can we see in the fog of healthcare? Well, 40 years ago, Jack Wenberg, who went from Hopkins to Burlington, discovered something very unusual. He went there to try and document that some people in Vermont were getting far less care than they needed. In the process, he discovered that variation in rates of surgery were dramatic. You could grow up in one town and be 3, 4, 5 times more likely to have your tonsils out by the time you were 15. You could grow up in another town and be 6 times more likely to have your uterus out by the time you were 55 than in another town. So geography was destiny. The medical care wasn't driven by the science. The care you got depended more on where you lived and who you saw than who you were and what you cared about. So what else can we see in the fog of healthcare? That work extended to what's now the Dartmouth Atlas. Over 3,000 hospital market areas coalesced around 3,000 hospital referral regions. People who live on the West Coast are twice as likely to have back surgery than people who live on the East Coast. People who live in Seattle, men who live in Seattle, are 6 times more likely to have a radical prostatectomy for prostate cancer than men who live in Connecticut, but they're also more likely to have alternative treatments for prostate cancer. The real variation here is how hard you look for the cancer in one place as opposed to another. There's also great variation on the little things. You know, there are 80 million people, 80 million adults over age 20 with hypertension in the United States. I'm sure there are quite a few here. And occasionally you'll get your blood pressure medicine changed. And you'll be told to come back to monitor the effect of that change. You could be told to come back in 2 weeks, 2 months, 2 years. And no one has done the experiment to tell us which is the best. Given that there are 80 million people with high blood pressure, that's a pretty expensive bit of ignorance, isn't it? Do you know that there are some parts of the country where people see 80 specialists in the last 6 months of life, others where they see 18, where they spend 60, 70 days in the hospital in the last 6 months of life, others where they spend 27, 10 days in the intensive care unit, others where they spend 2. Again, huge financial costs, but real human costs too. The majority of people who say clearly that they want to die at home die in the hospital. This work has been going on for a long time, emanating from Dartmouth. It took Atul Gawande's article in June of 2009 to catch the president's attention. And what he said was, this is the problem we've got to fix. And again, I'm here to tell you that you don't realize that you're the only ones who can fix it. I think that if you think about leading us out of the fog and how you can do that, it's worth pausing for a minute and thinking about leadership in the fog of war and in the fog of healthcare. It's pretty clear. Rules of command are pretty clear in the fog of war. An officer gives an order, the troops follow or face court-martial. It's different in healthcare, isn't it? You don't face court-martial if you don't follow my orders as your doctor. In fact, you know that it's my responsibility to look out for your interests and try to elicit your concerns. What does this illness, the potential treatments, the potential outcomes mean to you? You are the principal. I am the agent. The goal is to be sure that you get the care you need and no less, and the care you want and no more. This is a very simple rule that people who talk about complexity point to as the way out of the fog. Simple rules, direction setting, the care you need and no less, the care you want and no more. A second simple rule, there should be no decisions made in the face of avoidable ignorance. Anyone want to argue with that? Every decision about health and healthcare should be informed by both professional knowledge and personal knowledge of the kind that we've been talking about. And if we can do that, we're not just talking about your welfare and the costs of healthcare, because if we had your knowledge, we would be doing far less aggressive care in lots of domains that we don't have time to talk about. If we had your personal knowledge factored into decisions, we would also have your revealed preferences. Those of you who remember Adam Smith in The Wealth of Nations, unless we know what you care about, unless you're informed enough about the choices that are made to reveal your preferences, we have no information with which to shape the healthcare system by investing or disinvesting in different capacities to do things. Might we have too many intensive care units? Might we have too many cardiac care surgery suites? So we've lifted the fog a little bit. The care you need and no less, the care you want and no more. No decision about healthcare and health and healthcare should be made in the face of avoidable ignorance. This may all sound good, but it's going to be hard. It's going to be hard. I'm not sure that you appreciate how hard it might be. First of all, you have to up your curiosity. I've been trying to do that. You also have to recognize that you need some competence. How do I understand my choice in the context of my values and preferences? This is hard stuff. The uncertainty applies to all of the diagnostic tests. Those of you who learned Bayes' theorem in finite mathematics, I learned it from John Kemeny, recognize that part of this fog of healthcare is the haze of Bayes. It's hard to keep these conditional probabilities and other things sorted out. Computers can do it easily, and that's where decision support comes in. But you're at least going to have to recognize the importance of understanding the pitfalls that one can fall into. But in addition, there needs to be courage. How do I accept, how do you accept the personal responsibility for decisions that influence health? You're not going to have to do it alone. The complexity of healthcare requires that the best thinkers from across disciplines come together. That's where the ideas for innovating and developing healthcare that minimizes the misalignment of interest between patients and physicians, between principals and agents, that contributes so much to the waste in our healthcare economy. That's where that comes in. And we're not just talking about the science disciplines, medicine, public health, the hard sciences. We're talking about the social sciences, and we're also talking about the humanities. But the best thinkers across disciplines need to be intentionally connected to the best doers across contexts. The very best ideas for redesigning care will succeed wonderfully in some contexts, but fail miserably in others. Unless you have a portfolio of contexts, you're going to discard some very good ideas. And both the thinkers and the doers need to be working very closely with the best communicators. We've always had a focus on basic science in medicine in this country. I've already alluded to that. What is the pathophysiology? Clinical science, what is the diagnosis and the appropriate intervention? The first Center for the Evaluative Clinical Sciences was founded here in 1989. And that's the question, does the intervention work and is it valued? What we're talking about is applying the same discipline of science, but also discernment from gathering experience from across contexts. And we're calling that the science of healthcare delivery. I want to close with one quick story. Jack Wenberg was not the first to discover the variation in tonsillectomy rates among children. J. Allison Glover did in 1938. He called it the strange bare facts of incidence. Children in different school districts in England and Wales were 10 times more likely than others to have a tonsillectomy. mortality rates with tonsillectomy as opposed to medical treatment were 8-fold higher, 10-fold greater exposure, 8-fold greater risk of death. When he read that paper on Wimpole Street at the Royal Society of Medicine in 1938, the representative from the Medical Research Council said, "This seems to be an operation done for no particular reason and no particular result." The president of the Royal Society of Medicine said, "Yes, and isn't it a shame that so many children died, anesthetic deaths, for an operation with no proven benefit?" The same variation in tonsillectomy rates within countries and among countries persists to this day. Remember the curiosity. What if a parent had asked, "How do you know that this is right for my child?" What if you asked, every time you had a recommendation, "How do you know that this is right for me?" If not here, now, and us, where, when, and who will fix healthcare? Thank you.